Well, great. It's now 2:30 Eastern, and we'll go ahead and get underway. Welcome to everyone who dialed in today. My name is Francis Campion. I'm an internal medicine physician here in Boston and one of the research leaders here at MITRE. Very happy to have a distinguished panel today to discuss convalescent plasma and monoclonal antibody therapies for COVID-19. We started this lecture series and webinar format last March at the beginning of the pandemic and never thought we'd be at it still this time later. But the pandemic is raging, as we know, and we have such a great promise now with new therapies, and we want to spread the word about the opportunity to use these new therapies to treat patients and to keep our hospitals from being overrun. Today, we're happy to also have the opportunity to offer this program for CME through Michigan State. If you check the chat window, you'll see the instructions, which are also on the screen. If for some reason you aren't able to copy this down, feel free to just send a message in the chat and we'll make sure you get this full information. There's a month window after the webinar in order to get your CME. So with that said, I will stop sharing my screen. I just wanted to say welcome to all. We will get underway now, but before that, I just want to see if Dr. Jay Schnitzer, our Chief Medical Officer from MITRE, would like to say a word of welcome. Jay?
Thanks, FX. Yeah, just 2 words. I just want to welcome everybody to this excellent webinar. We've got a really wonderful panel, and the agenda couldn't be more appropriate for this time. As FX said, we're entering this phase of the pandemic where unfortunately things are getting worse rather than better at the current time, and we really need to ratchet up our abilities to deal with it. And so the lessons learned from this panel, I think, are going to be very, very applicable. So without further ado, back to FX, because we really want to hear from the experts. Thank you.
Great. Well, thank you. We have 5 panels today. After we have their short presentations, we'll proceed with the Q&A portion, and the questions will come from each other on the panel, myself, Dr. Brian Anderson as well. We'll lead off with initial presentation and conversation presentations that relate to convalescent plasma, followed by monoclonal antibodies. And so I'll let each of our panelists introduce themselves, and in the course of their conversation, you'll learn more about them. We have Dr. Nigel Paneth from Michigan State, Dr. Lee Zamperovsky from Albert Einstein College of Medicine, Dr. Shmuel Shoham from Johns Hopkins, Dr. Alpesh Amin from UC Irvine, and Dr. Brandon Webb from Intermountain Healthcare. So without further ado, I'll have Nigel go ahead and show your slides and give us your overview presentation. And we'll just have the other panelists turn off their videos, and we'll come back on when we do the panel.
Yeah, thank you very much, FX. Make sure I've got this going right. Can you see the slides? Can everyone see the slides?
Yes.
Okay, very good. So thank you to MITRE Corporation, to FX, to Jay, to Mary Jo for setting this up. And I would just like to say that the first 3 speakers, myself, Shmuel Shoham, and Lisan Perovsky, are all part of the leadership team of the National COVID-19 Convalescent Plasma Project, which started in March and basically started to try to figure out whether convalescent plasma would be helpful in this epidemic. And we had no information in March, and now we have much more information. But in the middle of an epidemic is not, by the way, the ideal time to develop the best evidence for clinical decisions. And so our database is imperfect. And my goal today is to share the key features of the evidence we have, which I do think point towards substantial value for using convalescent plasma if it's used early and properly. Before I go to the randomized trial data, which is the essence always of any assessment of treatment, I'll make 2 points. There have been more than a dozen observational studies in which treated patients have been matched to untreated, which is of course not quite as good as the randomized trials, but some of these have been very sophisticated. And I'll just mention that nearly without exception, these observational studies have shown that recipients of convalescent plasma have lower mortality or do better clinically. The second point that has to be made is that convalescent plasma is very safe. Plasma, which is essentially identical to convalescent plasma, except it doesn't come from recovering people from COVID, is used 5 million times in the United States every year with a very low burden of side effects. So let me turn to the trials. There are 10 trials now in the public domain from all over the world. Interestingly enough, none of them from the USA. And 7 of them, in 7 of the 10, there was lower mortality in the treated convalescent plasma treated arm. 2 had identical mortality in the 2 arms, and 1 tiny study, the one that I list here is India 3, had 1 death in the control arm among 15 people and 3 deaths in the treated arm among 14 people. So if you put them all together, you get a pooled relative risk of 12%, or 0.76, a 24% reduction in mortality, a 12% mortality versus 16% mortality. Now, if we divide those 10 trials into 2, looking at the ones who were treated after 4 days of hospitalization, or those that were treated within the first 3 days, you see a difference in the relative risks. It's not a very large reduction in the ones who treated late, but a very substantial reduction in the early treaters, down to a relative risk of 0.44 in those 4 trials. And also that is also clinically, statistically significant. And notice also that in the trials of people treated early, the mortality was in general lower. The pool of patients treated early is a healthier pool. They're not selected for having progressed already further. And only one of the 10 trials just recently published, I label it here as Argentina 2, was the only trial conducted in outpatients. And that was a very interesting trial, just published a couple of weeks ago in the New England Journal, Lipster et al. They randomized 160 outpatients who had mild COVID-19, but within 72 hours after onset of symptoms. In fact, the mean number of hours after onset of symptoms is 40 hours. All participants were over 65. If they were under 75, they also had to have background health conditions. They all transfused units at IgG titers greater than 1 to 1,000. The endpoint was severe respiratory disease, and that was halved. That endpoint was halved in the treated group, 0.52. And if you look at the 36 people who got plasma with very high, with above the median IgG, which in this study was a dilution of 1 to 3,200, very few progressed to severe disease. There was actually a 73% reduction in that outcome. And that meant that the number needed to treat was 4. That's extraordinary, rarely seen in so far in any outcome in this disease. I'd like to say that this was the only trial that followed the central principle of the use of convalescent serum from the great days of the use of convalescent serum in the 20s and 30s, which was treat in the first days of illness or don't bother. So now let me turn to another topic, the antibody findings, another piece of evidence that's very important. And that also suggests that convalescent plasma works. I've already mentioned 1 antibody finding, but there are much larger databases. 2 large analyses have been done in the US using the same database, but with a different patient pool, partially overlapping. In the first, and in these studies, in both of these sets of studies, the antibody in the plasma was determined by looking at remnant serum kept by the blood banks for that particular unit. They were matched to the unit transfused, so we could determine who got transfused with what level of plasma. Now, the first analysis, which is on the FDA website, you can find it there, was published at the end of September, shows that in almost 3,000 patients, if you looked at everybody, The people who got the upper half by titer, and this was, by the way, using the Broad Institute neutralizing antibody titer test, had slightly reduced mortality, not significant, but that included a lot of patients who were ventilated. If you look at patients who were not ventilated, there was a 16% reduction in mortality. And if you restricted your attention to those who were treated in the first 72 hours and were less than age 80, there was nearly a 30% reduction in mortality in those who got high levels of antibody in their transfused plasma. The second analysis has just been published, as FX was saying, in the New England Journal of Medicine by the Mayo team, and I'm happy to say I'm part of that team. Mike Joyner is the first author from the Mayo Clinic. In there, we did some sophisticated adjustments for allowing for any small differences between the treated and the untreated groups. But anyway, and we also divvied it up into people who had the lowest titer, a medium titer, the middle 60%, and high titer, the highest 20%, using a different antibody test. This was the ortho-IgG. And as you'll see here, in all patients, there was a reduction in mortality that was modest, but in the unventilated patients, again, confirming using a different antibody test and an overlapping but not identical set of patients, there was a substantial reduction in mortality of about a third in people who got high antibody plasma. Now, as we contemplate, as looking at all the data we have in front of us, as we contemplate how we make decisions in this particular moment of an epidemic, I'm asking, should we worry about type 1 error or type 2 error? Now, trials are designed largely to guard against falsely believing that a treatment works when it doesn't, which is a type 1 error. But sometimes we need to worry more about the type 2 error, of falsely believing a treatment doesn't work when it really does. In an epidemic situation with few options for early treatment and a product that's demonstrably safe, the risk of not using plasma when it's appropriate to use, i.e. early use with high titer, seems to me greater than the risk of using it. Now, before I finish, I have to say that a news release came out just a few days ago about the recovery trial. It's a very large trial done in the UK, and it failed to show a difference in mortality in the people randomized to convalescent plasma. But I want to note that this was a very high mortality cohort, 18% higher even than the trials conducted in people who got late plasma. So I have to infer from this mortality rate that the patient population treated was very high risk and probably in the category, much as in the ventilated patients and the late treated patients we saw before, who really don't have a chance of really benefiting from convalescent plasma. But of course, we've only seen a brief news release, and we'll have to wait until the final results, which I hope will be published soon. And then we'll see and interpret those results. Hopefully they'll be broken down by level of severity of the patients treated. My conclusion is treat early, as soon as admitted with convalescent plasma. And when the FDA allows, which I hope will be soon, on an outpatient basis. At the moment, the emergency use authorization applies only to inpatients that the FDA gave us in late August. And of course, please use high antibody titer plasma, or if unavailable, use multiple units. Now, as you may also know, that the FDA mandated that all convalescent plasma units be labeled as to whether they high or low antibody titer, so you will know if you're treating whether you have high antibody plasma, and hopefully you will have enough plasma. We're working very, very hard on donations to be able to treat all of your patients. Thanks very much. I'll stop here.
Thank you very much. So go ahead and stop sharing if you would. And then that was great, and conjures up lots of questions about the tempo of the studies and what time they were initiated as far as the pandemic goes, because a lot of learning has gone on. Why don't we go ahead and move straight to Lizanne Porofsky from Albert Einstein and the Montefiore Medical Center Dr. Porofsky is actually heading up one of the large RCTs for inpatients in the US, so she may be able to share with us the challenges of running a big trial during a pandemic. She's going to focus on some of the biology of antibody therapy. Please, Ann.
I'm sorry. Our favorite word, I was on mute, excuse me. Good afternoon, everyone. I'm Lisanne Porofsky. I'm Division Chief of Infectious Disease at Albert Einstein College of Medicine in Montefiore. And for the 30 plus years before this pandemic, I worked on antibody therapy, mechanisms of antibody action, but in mice. But since the pandemic, I have turned to people. And as was mentioned, I am running a large trial that I will make a few comments about in the end. But let's delve into the plasma. So you heard from Nigel that it's good stuff. And so I want to walk it back a little bit and just remind you a little bit about the antibody response to this virus and how we need to leverage it in order to use the stuff that we make ourselves to treat other people. So in figures that I'm sure you're all very, very familiar with, the antibody response to the SARS-CoV-2 virus begins somewhere between the first and second week of illness. Generally at the time, we think when the patient is already manifesting symptoms, and obviously the logic, the ideal logic of antibody-based therapies in this whole early thing is really to try and treat people before they begin to manifest illness. But let's talk about this for a minute and talk about how robust the response is. So we've learned a lot about the antibody response to this virus, although I guess we could say the more things change, the more they get the same or are the same, since a lot of it is like SARS and a lot of it is like MERS. So we know that most immunocompetent people, they make antibodies to the virus. We also know that the level of antibodies that they make correlate with neutralization. And by the way, that includes IgM. And we also know that people's antibody levels vary by age, male sex, severity, all of which are probably related and related to the viral load and possibly other factors. And you can see here, this is a severity scale in a very nice paper that I think is about to come out from the Houston group, showing higher neutralizing, higher receptor binding domain spike protein, IgG, and IgM in patients that are sicker. I will also draw your attention to this really beautiful work from the Mount Sinai group, showing the correlation between antibodies to the spike protein by ELISA and neutralization. Now, of course, if we're in the business of trying to leverage this as the therapy, we're interested in how long the antibodies last and when we should be collecting them from people. So again, we've learned a lot. In some people, antibodies disappear quickly, and that's mainly in people who are have asymptomatic or have mild disease. And this is a beautiful paper from early in the pandemic, basically showing that while early on people's antibody responses may be similar, that they decline much more quickly in people that are asymptomatic. But there are plenty of people that have pretty long live responses, and we're learning that now. And again, another figure from that paper from Mount Sinai, showing that over time, people who had an initial titer that was a reasonable titer on their platform had antibodies for a long way out. On the other hand, there is concern that neutralizing antibodies may disappear from the plasma quickly in some people, IgM sooner than IgG. And here's some decay in antibodies to the receptor binding domain from the Houston group, sort of showing that after about 2 months, that there is a decline in the antibodies that we hope are the ones that we would be giving to patients, suggesting that maybe the donation window is in there. Now, which antibodies are protective? What is, why are we all so focused on RBD and spike protein? And So there are two major antigens that we need to really take into consideration from this virus, the spike protein and the nucleocapsid. And here's some really gorgeous work from Galit Alter's group at the Ragan, showing that people who convalesced and survived versus people who died had a higher ratio of spike to nucleocapsid antibodies, whereas the reverse was seen in people who died, again, focusing on spike protein antibodies and their mechanisms of action. Now, I do need to tell you, because I'm always sort of a person that I won't say I'm disruptive, but we were focusing a lot on neutralizing antibodies for good reason. We've looked for them and we found them. But I need to remind you that antibodies work in many, many ways, and they don't always act alone. So in addition to neutralization, we know that in any robust antibody response to a complex antigen, there are likely going to be antibodies that work in a different way. For example, that work with Fc receptors to promote opsonization or phagocytosis, or antibody-dependent killing, or that fix complement and promote complement-mediated microbe lysis. And again, to remind you that antibodies also have the potential to work as immune regulators by binding to different Fc regions, inhibitory versus these activating ones. They have the capacity to be anti-inflammatory as well as pro-inflammatory. And both of these effects are probably going to be very important in really modulating an immune response. And the data to support that actually comes from Dan Baruch's vaccine, which we all are awaiting with bated breath to learn more about. So his preclinical work in macaques showed that yes, the neutralizing antibodies that presumably block uptake and maybe work on their own were highly correlated with protection. But you know what? There was also a pretty good correlation with other mechanisms of antibody action, including complement-mediated viral lysis, as well as antibody-dependent NK cell activation. So if we think about the course of the disease and when we want antibodies to be working, we're all very focused on, and for good reason, controlling the virus, because we know, again, that early in disease, as Nigel laid out very well, the virus is the problem, and giving something that can control the virus is going to be a really great thing. But we also know that very unpredictably people can deteriorate. And it seems to me and others that other activities in plasma and other antibody-mediated functions, perhaps that leverage Fc regions or other molecules, may be very helpful. So if you think of it in this schema, that the early antibody response is very effective, actually, as an antiviral, and I'm excited to hear about the monoclonals, because I think that they really put this on the map. And by the way, I want to give them credit for lots of things, but for really helping us all understand that the antibody response can be part of the primary control of a viral infection. This is really amazing. But later on, antibody may have additional effects in terms of immune modulation. And the thing to think of here is that all those so-called failed studies that Nigel referred to, many of them you will see the CRP went down. There was a dampening of the inflammatory response in patients who got plasma. So I think we have a lot to learn about additional activities in the plasma. I want to just make a hard stop there, say thank you for listening to that part, and tell you a couple of things about our trial. So this is a pragmatic trial, okay? I work in the Bronx. We were the epicenter, and by the way, we are not flattening as I speak right now. And so we designed a study way back in April, was launched in April, to really see whether this stuff is going to work in hospitalized patients. There is no question, use early, use often early, give a lot, but is this going to be a viable modality for patients in the hospital? So we designed a trial of, I would say, moderately to severely ill patients, randomized 1-to-1 to placebo, which is saline, it's double-blinded. And we are going for 1,000 participants because NIH and Operation Warp Speed are now funding this trial, and they told us to go to 1,000. We're at 750. We have multiple sites. The primary outcome of this is not mortality. it is clinical status at 14 days and 28 days. And I do want to shout out to the Mathers Foundation, which is a donor at Montefiore that gave me money that really launched this entire thing, other than the wing and the prayer of our 2 medical centers until NIH came along. We have a DSMB review Friday. Please all do whatever you do to, like, you know, make something good happen, and we'll see where we're at. And I just, you know, do want to just, again, as Nigel said, I am also a member of this group, but I'm a division chief. I've been supervising faculty during this time. It's really been an experience. My lab has pivoted to look at STARS antibodies. My chairman has been enormously supportive of our efforts, as have the hospital and medical school leadership. We're not a place that traditionally does large randomized controlled trials in the ID world. And I also just want to shout out some of our PIs along with me on this trial, 2 young female physician scientists who really are the future. And every day that I get depressed, like today, because it's the day that my mother went down and didn't wake up, you know, I think of these young women and our vice president and it does make me really happy. So I think there's hope. Thank you for tuning in, and I look forward to your questions a little bit later. Thanks a lot.
Thank you so much, Lisanne. Thank you for helping combat COVID since the very, very beginning with your amazing intellect and devoted team. We'll now call on Shmuel Shoham. Shmuel's an associate professor at Johns Hopkins, and he's also leading an RCT, really exciting 2 RCTs in the very early use of plasma, including ambulatory and even a prevention trial. So Shmuel, please take it away.
Thanks. Can you see my slide?
We can.
Great. So I'm a little bit humbled to follow 2 both fantastic speakers and in legends in their own field, and I'm hoping that as the number 3 batter here, I can knock them home. So I'll start with a case, 58-year-old man with kidney transplant and exposure to his son with COVID-19 at home. And he now has 3 days of cough, fatigue, myalgias, and diarrhea. Tests positive for COVID in the ED and is admitted to the hospital with oxygen saturation on room air of 94%, but it drops when he walks to the bathroom. So I think this is somebody just on the cusp of needing hospitalization. And when you look at the menu of options that are available right now that are approved or emergency use authorized, essentially the only thing that's really available to him is plasma, because remdesivir is approved, but at least in our hospital, they want people that are requiring oxygen. Steroids are something that's used, but for people that require oxygen, and so plasma is what is widely available and widely used. And where does it kind of fit in? So here are the various groups of patients, and you can even cut them even further, but I would say pre-exposure, prophylaxis, post-exposure, which I'll get into a little bit later as a study that we're doing, outpatient infection, which as Nigel mentioned, this study from Argentina showing that it could have a use, inpatient infection, which is where Dr. Porofsky is studying them, ICU infection, which may have a role, but less so as an antiviral, maybe more as an anti-inflammatory there, and then persistent viral infection, the people that just won't become negative, perhaps there could be an antiviral role there as well. So all those are worth studying, and some of those we now know more about than others. We're using a lot of plasma in this country, and some of it is I would say evidence-based, based on the evidence, as imperfect as it is, that we have now, where earlier use with a high titer is probably the most helpful. Some of it is desperation-based, because patients are sick and we don't have very much to offer them, and there could be a benefit, although the various studies may not have picked up the benefit as a population. It could be that for an individual patient it's beneficial, and we've used, I believe, somewhere between 300,000 and 400,000 units of plasma in this country so far, and tens of thousands of units are used weekly. This is in terms of the lineup of where plasma might work, and you can see that early on in disease, this is where historically antivirals for respiratory viral infections and for some other viral infections have been most effective. And you could look at it as convalescent plasma as an antiviral in that context, and then an immunomodulator that's less clear, but emerging data to look at the role of plasma as an immune modulator. But at least the best data that we have now in terms of as an antiviral, which suggests that early on is where you're going to get the antiviral activity before the disease takes on a different direction that is not driven as much by viral replication, but is more driven by the immune response to the virus. So with that in mind, and picking up what Nigel has said, early better than late, high titer better than low. And here's some historical examples where that's played out. This is a slide that was lent to me by Dr. Porofsky looking at epidemic meningitis. And here you can see when used very early, the mortality was 18.7%. When used late, the mortality was higher. When not used at all, the mortality was even higher. And it also served as an equalizer for both Caucasian kids with the meningitis had a 74% mortality, went up to 91% for African Americans when not treated. But when treated, those numbers close to equalized out, showing that access to therapy made a difference. In going into the animal model, so that was historical precedence. Into the animal models, these are hamsters, and when hamsters were given titers that were high, 640, versus titers that were low, the amount of virus in the nasal turbinate went down by a log. A little bit more than a log. The amount of virus in the lung went down by almost 3 logs. So really a huge impact in as an antiviral when given with high titer post-infection. When you wait a little bit longer, then some of this activity of the antiviral activity goes down. You can see 6.7 to 6.3 log in the nose, and still something significant, but not as dramatic as before in the lungs. Staying in that same vein, now moving on to African green monkeys that were, this is their control lungs here. You can see a lot of ischemia, a lot of necrosis. As low doses given, some ischemia, some necrosis. As the high dose is given, this picture is a little brighter, so it may look more dramatic, but there's actually less ischemia and less necrosis with the high dose. Similar in the BAL, this is control monkeys that did not get any therapy, and over here are the high and the low dose, and you can see that you can really knock down the viral load in the BAL. Interestingly, in the lung parenchyma itself, it's not as dramatic, and that is I guess not surprising when you think of where antibody historically works. It works before the respiratory viruses tend to get deep into tissues. It takes other parts of the immune system to really root them out. So the antibodies are still doing something, maybe with the collaboration of the other parts of the immune system, but not as much as they are in the airways themselves and in the nose. Building on that, you've heard about the clinical trials and the interpretation of the clinical trials. Couple of clinical trials that we're doing at Hopkins and nationally, and when I say nationally, ranges from Annapolis in the East Coast all the way to UCSD in the West Coast and Navajo Nation and multiple other places in between. And this is our website. If somebody is positive but is still an outpatient, they can be part of the clinical trial where they get high titer plasma versus normal plasma. And we're measuring outcomes, or if they've been exposed but don't have the infection yet, they can get, again, high titer plasma versus normal plasma that does not have antibodies in it. The post-exposure prophylaxis, that's the people that do not have infection yet. We set it at 500 subjects. We probably won't get that far. We're at 150 now. I think a more realistic number will be 250, but we do have it set up for up to 500. Inclusion is grown-ups who have had an exposure recently, and then they're blinded 1-to-1 to get high titer plasma or normal plasma, and it's done at multiple sites across the US, and the outcome is prevention of infection. The twin to this study is the outpatient treatment, bigger number of subjects, and we're more than halfway there now. About over 600 subjects have been enrolled so far, greater than 18 years of age. Again, it's for grown-ups, people that aren't quite sick enough to be in the hospital and haven't had the infection for more than a week. The goal here is prevention of hospitalization or death. And some of the just transitioning from the studies to what everybody needs to make this happen is you need clinical champions, people that really care about trying to get products to people. You need a blood bank champion, somebody that can help you with the blood bank issues, and you need administration champions because it is something that is just different than the way things have been done before for treatment of infectious diseases. And with that, I'll finish with a thank you to the hundreds of people that have worked to make plasma research and plasma administration a reality. Very early funding from my university to get us going, and then Bloomberg pitched in a lot of money. The governor of Maryland pitched in some money, and then that allowed us to leverage to get funding from the Department of Defense and other federal funders. So, and then these are the very brave women that are out there manning our research station, and they're not wearing PPEs right now at this very second, but they do wear it when they see patients both that have had an exposure and therefore are at risk for actually having infection and being very contagious as they test them to make sure that they're not actively infected and therefore can be in the study, or people that are actively infected. And they do this every day out here in a parking lot in Baltimore County. And we really owe them and the hundreds of people a huge thank you.
Thank you, Shmuel. That's a fantastic review in a very short time of some of the animal models, plus the emerging work. And just doing this work in the ambulatory is really groundbreaking. And it's something that we're certainly looking forward to the findings in the near future. We're now going to switch gears and focus on antibody therapy. And we're really happy to have Dr. Alpesh Amin, who is well known as a pioneer in hospital medicine, and he's currently the professor of clinical medicine and chair of the Department of Medicine at UC Irvine in California. We know you are busy these days at your facility. So, Alpesh.
Thank you. It's a great pleasure to be here. I'm going to share my screen really quickly. Can you all see that?
Yes.
Perfect. So thank you. It's a great pleasure, as I said, to be here. And let me see if I can get this slideshow going. Okay, great. So I was asked to talk about monoclonal antibodies and their role in COVID-19. And I thought that, I would take it from, and I want to first actually thank MITRE and the coalition and actually even Operation Warp Speed for all the support and collegiality and conversation that we've had in the recent weeks on some of this aspect, and thank you for inviting me. We have been as I've been kind of leading some of these efforts on COVID-19, we've had a great learning experience over the past 8 months, and I'm going to kind of take this slightly different perspective, both combining the value of science and operations in order to hopefully look at how we look at the world in terms of improving public health and population health in some sense, using the goals of monoclonal antibody. And so, our critical need here in Southern California, Orange County, we're the 6th largest county in America. We're very close to we're adjacent to probably 4 of the largest counties in America, also with LA County, San Diego, Riverside, and San Bernardino. So huge population and ground, as you can see here. And we've obviously been dealing with a fair amount of surge that's been going on. And we, UC Irvine is the only academic medical center in Orange County. So we feel like we have a responsibility to really not only care for our patients, but also to care for the county in a big way. And so we've seen a 420% increase in our hospitalization across Orange County during the month of December. And that obviously starts straining our bed capacity and straining nursing ratios. And here in California, we have a really a strong nursing process. We have ratios that are very strongly adhered to in California, and we've seen that local hospitals have had a very tough time maintaining those ratios during this COVID surge. For a general med surge bed, it's a 5-to-1 ratio, and for telemetry, it's 4-to-1, and step down, it's 3-to-1, and ICU is 1-to-1 or 2-to-1. So, but we've had folks that have gone up to 8, hospitals have gone to 8 or 9-to-1 ratios. So that these have been real issues for us. We obviously feel like we're positioned geographically to deal with some of this. Our main medical center is located in North Orange County. Based on kind of the demographics of the population, as you can see in this bottom slide, the county's kind of racial profile, if you like, and then the critical COVID patients and non-critical COVID patients, but they mirror the county's racial breakdown across the board. And certainly there's been a bigger impact to North Orange County than there has even to South Orange County in a big way. We're very thrilled, honestly, that we have such a diverse population here. So we kind of raised the question about monoclonal antibodies and as a potential solution. The FDA obviously approved it through either Regeneron or Eli Lilly's monoclonal antibody, and we were working through the issues about supplies and them being limited, but we also, as you all are aware of, there's a significant reduction in hospitalizations that are associated with patients that have mild to moderate symptoms for COVID-19, and in terms of preventing the risk for progression to severe illness. Our challenges have sat around limited supply and difficulty identifying high-risk patients that are amenable. There is a point scoring system that has been published, and we have applied that, but we also felt that our hypothesis is that there are other patients that we think the monoclonal antibody can be very useful in terms of impact, and that may be even beyond our the published criteria of inclusion. The other thing is that, from a bed capacity perspective, our most valuable resource, it's funny how you go through a pandemic, and one of the things, you grow up and your grandmother tells you, water and oxygen are really lifebloods for living beings, and we don't think about it all that much, but now we're really thinking about oxygen and oxygen supply issues, and we're also thinking about bed issues. And so, so the question is, can we, could we impact the opportunity to utilize beds and think about bed flow? We have in the past, over the holidays, I've personally been very involved in increasing our bed capacity by 50 ICU beds, 50 or so med-surg beds that we licensed in a matter of 10, 12 days. We added a mobile hospital, of another 50 beds, but increasing beds is just one side of the equation. Then we actually went out, and one of the things was how do we really think about streamlining discharges and streamlining the process. And then the third phase of our plan was how do we deal with avoidance issues, avoiding patients from hitting the ER or the hospital. And this is where monoclonal antibodies kind of come in, because every patient that you avoid means that you have a bed for somebody else. So we looked at the targeted high risk selection group and the indiscriminate general selection group, and we showed we hypothesized that for every 12 patients that we treated would equate to 1 reduced hospitalization in the targeted high risk group, and every 23 or so patients that were treated in the indiscriminate group, we would reduce 1 hospitalization. So we had a problem we wanted to solve, which was create a solution that can better identify patients who may benefit from monoclonal antibody to reduce the stress of increasing hospitalization needs. Now, in order to do that, we needed to also find an infrastructure and create an infrastructure. So I took our digestive disease building that we have, and we took one area and created a closed loop infusion center for monoclonal antibodies, so that these COVID positive patients would come in but not be exposed to other patients and could get their monoclonal antibody infusion and then go out, and right in front of it is a valet area that we had. And so we created this infusion area, and which allowed us to expand the program. 6 infusion chairs, Monday through Saturday availability. We can even go Monday through Sunday now, 8 to 6, and we can expand those hours. And we develop workflow processes and centralized scheduling, and put in a designated nurse practitioner to really streamline the process. And the whole idea is to develop a system where patients are either in their own, if they're part of UCI Health, they're seen in the practice, identified, tested, scheduled, and gotten their antibody infusion in a matter of 4 hours, and they're out. That's the process we wanted to develop. If they were a referral patient to our organization, then we worked on streamlining that process also. You all know the published inclusion-exclusion criteria for monoclonal antibodies, right? They test positive. They have symptoms within the past 7 days. They're mild to moderate. They aren't required to be hospitalized, and it allowed us to manage it. There's a set of exclusion criteria that you can see here, that are pretty easy. And then there was a published point scoring system that you see here. And if you had 4 or more points, you were able to get the monoclonal antibody infusion. So when we looked at that, we said, okay, we will certainly use the risk factor based selection system, but we also asked the question, because when COVID first hit back in February, one of the first things I did when I previously, over the past couple of years, also served as chair of radiology. And one of the first things that I did during that tenure was develop a artificial intelligence, imaging center. And so using that center along with being able to create, a group of COVID patients, we asked the question whether our own experience with AI, could we develop a tool that would help us risk stratify patients? And our first forte in it was we developed an AI risk stratification tool to ask the question about COVID patients that would be at a higher likelihood of requiring an ICU or be intubated in the next 72 hours. And that tool came out to be really helpful in terms of our ability to streamline operations, make decisions about COVID patients. So when this came into play with monoclonal antibodies, we asked a separate question using the AI tool that we developed and said, could we actually risk stratify patients that were beyond these published criteria that we could potentially use for COVID patients, and therefore streamline the treatment of them. And our initial, we have been, and then our goal was really scaling up. We want to do 20 to 30 patients a day, and we were able to hypothesize a number needed to treat in these various different categories. As you can see here, I've gone through some of those numbers and how many hospitalizations we would be able to reduce and potentially how many hospital days that we would save. And our experience, our own individual experience on COVID patients was our average length of stay is now down to actually 6.7 days, when the national average is running in the 8 to 9 days. And so we've developed really good streamlined processes, but we have these issues about oxygen supplies and nursing staff. Well, with monoclonal antibody, could I help with these supply issues by using monoclonal antibody and reduce the burden on a healthcare system? So that was the whole program and plan that we created. In our first 106 patients that we looked at, and we've done more than that now, but in our first 106 patients, we actually looked at and we found that based on the EUA criteria, 87% of them went through that, and another 13% went through our what we call vulnerable scoring system, which is the AI tool. And so we were able to parse out that there are more patients, additional patients that we can potentially treat beyond the EUA criteria. And so that's good news. And we have an infrastructure to be able to do it. And then we said, okay, let's start looking at our outcomes data, and we'll build on it as we go. And we've found that 3 to 3.5% of our patients still ended up getting to an emergency room, but that is 96, 97% that did not. So that data was really, really solid and reinforced the work that we were doing. And another 1%, actually, it's one of the patients that came into the ED needed to be hospitalized. And so it came out. So we were really happy with some of these results. And so we're trying to match science with operations, with delivery, if you like, as we're dealing with this pandemic. It's all built off of our initial work over the first 6 months that we have done, where, as you can see here, our observed length of stay in managing COVID through our pathway and through the things that I've designed, puts us in a pretty good position in terms of California and nationally, both in terms of length of stay index as well as in terms of mortality index when we compare to other institutions. So this, the monoclonal antibody was another way to refine it and add to it. And my last comment is, besides the AI tool and the opportunities of, we were early adopters with remdesivir, we also, just in the past, week or so, in a matter of 12 days, I developed a hospital at home program. And so now we're tying some of this into that hospital at home program, which in the first 7 days or so, 8 days, 10 days, we've enrolled 14 patients and have had great success with it. So we're tying these processes with hopefully science to improve, to deal with our pandemic. So with that, I think I'm going to stop and thank you for inviting me.
Thank you very much. That's an amazing process that you've developed on the fly. And Brandon Webb from Intermountain is now with us. He's going to be speaking a little bit about the innovation they've been through. He is head of their COVID therapeutics assessment program and part of the Division of Infectious Diseases. Brandon.
Thank you. Let me share my screen as well. All right, are you able to see my slides?
We can.
Wonderful.
Yes.
Well, I really appreciated Dr. Amin's presentation because it largely mirrored mine. And since we're close to time, that makes it easy to be efficient here. I wanted to highlight that, from the clinical trials, we did, although it wasn't the primary endpoint, the hard endpoints of hospitalization and medically attended visits did appear to be reduced. And although the trials weren't powered to detect that secondary endpoint in a statistically significant way, the signal suggests that there is reason for optimism. I wanted to point out that in the two trials, the number needed to treat to prevent one hospitalization was roughly 21 when using the criteria that now comprise the EUA. And in higher risk strata, the number needed to treat is smaller, roughly 9, as described in the BLAZE-1 study. Dr. Amin, I think, pointed out some of the real world challenges to implementing this program very nicely. These include the fact that these are contagious patients, that they require infusion, and oftentimes that venue for infusion is also shared by access for patients who require chemotherapy and other infusions for autoimmune diseases. And these are actually among our most vulnerable patients. Maintaining access for them and sharing with COVID positive patients is no simple matter. And then, of course, these infusions do have a small but non-trivial risk of infusion reaction and need to be delivered in a setting where that can be managed appropriately. And finally, the goal with this is largely a public health endeavor. Can these products be developed, delivered in a way that can prevent hospitalization? And in any situation where we have limited supply, in this case, the supply of drug is not the limitation, but actually the logistics and the ability to infuse, the capacity, if you will. Can we match the limited capacity to the patients most likely to benefit? And very similar to what Dr. Amin described, in Utah, we also developed a risk calculator, based it off of previous work that was done at Cleveland Clinic, and then validated it in a population here in Utah, and found that it worked quite well. And then we actually developed a simplified version so that clinicians could use it independent of their access to a more sophisticated model. And by doing that, we actually were able to identify a couple of interesting observations. One is that the law of diminishing returns is definitely at play when it comes to trying to prevent hospitalization. And I'll describe that here briefly. Using the EUA criteria as written, we determined that that would identify about 26% of all test positive patients in our state. And of those, the admission rate of that group was roughly 15%. And of course, the number needed to treat there we expected would be around 21. By applying a more risk-targeted criteria, in other words, by stratifying and targeting drug towards a patient population that was at higher probability of admission to the hospital, we were able to actually target the drug to a population where the number needed to treat was smaller and whose admission rate was greater, roughly 27%. And the ultimate and end product of that risk-targeted approach is actually a zero-sum game. With less resource utilization and a more risk-targeted approach, the same number of hospitalizations can be prevented. And we're doing that with a very similar approach. I won't belabor here. We're accepting referrals from ambulatory providers from the emergency department, and also prospectively screening patients at the time of test positivity and connecting them with their nearest infusion center. And we've so far been able to set up 17 infusion sites spanning a population catchment area of over 3 million. And to date, we've prospectively reached out and screened almost 2,500 patients. And for a variety of reasons that I won't go into here, not all end up either qualifying or desiring treatment. But to date, we've delivered over 500 infusions. And our observations at this point are summarized here on this slide. And I'll just briefly point out that this is a population with senior age, a median age of 66. Comorbidities are very frequent. The median number of comorbidities was 5 in our infused patients. And by calculated risk, these patients are in the 96th percentile for probability of being admitted to the hospital in the next 14 days. And that's more than 600% higher than the baseline adult population, where we see an overall admission rate of roughly 6%. Just by ballpark estimates, the estimated probability of admission to the hospital in the patient population that we've targeted is somewhere between 27 and 35% probability. And currently, among the 412 patients for which we have follow-up, we have a 14-day readmission rate observed of 4.1% and a composite ED or admission rate of 4.4%. And that compared to the counterfactual of what we would expect in that population gives us quite a bit of optimism that these are in fact doing what we expect. And I'll finish with just a note about some efforts that are ongoing both at our center and at many others to analyze these real world data using some statistical causal inference methods that allow us to, in a better way, estimate what the real world advantage is. Thank you very much for having me.
Thank you. Well, our hour has already gone by. I wish we had a second hour just for the Q&A, but I think we see compelling evidence now for both plasma and for monoclonal antibodies for a really robust role for addressing pandemic and taking care of our patients. So I encourage all those listening to go back to their health centers and their medical groups and to pursue the use of these important therapies. And feel free to get in touch with us if you have any questions. I did put the CME information again in the chat, and we wish you all well. We will be posting this video on our website for the C19HCC.org coalition. And thank you again to all of our speakers, and good luck with your own clinical trials and programs. Thank you.